talking about for people who have transverse myelitis, as well as for neurologists who treat people with transverse myelitis, by really taking the great risk that he was going to start a center at Johns Hopkins that would focus on research in transverse myelitis and care for patients who had transverse myelitis. He went about developing an understanding from learning something about the tremendous variability that exists in this population. We've all learned over the years just how different TM can manifest itself in the way of symptoms, and just how different the course of the disorder can be, and also just the tremendous variability in the causes. By virtue of his willingness to take on this focus, he has learned about what that variability means, and as a result of that, the treatment and the care for everyone in this room who has TM has improved exponentially. And really, there is no way to adequately and describe in words just how grateful we should all be for the risk that he took to say, I'm going to focus on TM. And in addition to the fact that he's a brilliant scientist who, I'm sure you've seen the work that he's done that has been all over the news for the last few weeks because of his stem cell work, he's also an incredibly wonderful human being. That may be his greatest trait. So thank you, Doug.
Well, thank you, Sandy. I get far more from this community than I ever give. I've learned so much from all of you, and feel like I've been able to be part of this community as we strive together to do better, and I'm grateful to all of you for what you've taught me. But let me talk to you a little bit about transverse myelitis and how we get there as a diagnosis, and we're going to start with a little bit of anatomy. Now, you've done a little bit of anatomy with Dr. Pardo, but let's do it again. So let's talk a little bit about the spinal cord. And the spinal cord is just really a conduit of tracts going up and down up and down to and from the brain. And it's a bunch of electrical wires. And if it's a motor pathway we're talking about, the electrical impulse starts in the brain and fires down an axon, down the spinal cord, hands off that electrical impulse to what's called a spinal motor neuron. And I'm going to show you a cartoon of this, I think. And then goes out to muscle, and the muscle moves. That's motor pathway. That's movement. 2 electrical impulses, 2 nerves or neurons, and they're long wires which are called axons. What sensation? Well, it's the opposite. Another nerve has its endings out in skin or muscle or joints. And when there is a painful stimulus, or in case of patients with transverse myelitis, sometimes when there's not a painful stimulus, that sensory nerve fires, carries an electrical impulse back to the spinal cord, where it's carried up to the brain, where that message is received, and you say, I've got pain, or I can feel some pressure on my legs. That's what the spinal cord does. And when those pathways, those electrical circuits are disrupted, you get weak or you get numb. Or if that sensory pathway is too irritable, meaning it fires when there's not a knife-like sensation on your leg, that's pain. That's neuropathic pain. And so that's the basis of anatomy. There's also the motor neurons themselves exist within a central core of the spinal cord called the gray matter, but I won't get into too much detail. Now, people with transverse myelitis have different symptoms. You can see this, obviously, varying degrees of weakness and numbness and tingling and bowel and bladder dysfunction. Well, why is that? The reason is that the spinal cord is organized with particular fiber bundles in particular regions of the spinal cord. So here is a cross-section of half of the spinal cord, and this is the patient's back. And so that in some cases, the transverse myelitis involves the back part of the spinal cord. Well, what are the fibers that carry in the back part of the spinal cord? Those are sensory pathways that mediate proprioception, knowing where your feet are in space. And so if the inflammation that defines transverse myelitis occurred preferentially in this blue area, that's what you get. Now, if it occurs only there, you will not be weak. The weak fibers would be here, so that if the inflammation occurred over on this side, you would be weak on that side of the body. If it occurred further up towards the front of the spinal cord, now we're talking about pain and burning sensations. And even further up really is the bowel and bladder pathway. So that's why patients with transverse myelitis have different clinical presentations. So myelopathy, that's a more generic or general term than myelitis. Myelopathy just means acute dysfunction of neural cells and axons within the spinal cord. And transverse myelitis is within that, but there are lots of other things. And some of you have other forms of myelopathies, and we think about these in terms of, okay, is the pathology within the spinal cord intrinsic, or is it extrinsic? Is it something pushing on the spinal cord from the outside? We know the spinal cord's not working, but we don't know what the cause of that is. Transverse versus longitudinal. Everybody now knows the relevance of that because of Devick's disease or neuromyelitis optica, which looks a bit different than many forms of transverse myelitis. And Dean Wingerchuk has done a wonderful job in trying to parse out what the differences are. And so we now view these as part of a spectrum of disorders. Transverse myelitis is on there, Devick's disease is on there, MS is on there, and there are a bunch of others. Now, everybody needs to remember this because that's what the test will be on, is this algorithm. And what this is this is something that came out of our 2002 Symposium, where we got a bunch of the scientists together, and all of us geeks over there in the other room back in 2002 came up with a way to approach and diagnose patients who present with an acute myelopathy. And so I'm going to go over this a little bit with you. I'm going to break it down so that you can read the parts. This is just to say, this is on our website, this has been published, and it is a useful tool for physicians, we think, to figure out how to approach patients. Now, before I get into that and telling you how we think about transverse myelitis and myelopathies, I want to just talk to you a little bit about our experience. When we have applied that algorithm, we've looked at now 554 cases. We've seen well over 1,000. But at the time that we did this analysis, we have seen in our clinic at Johns Hopkins 554, and we broke them down into these various categorizations, including compressive, non-compressive, but non-inflammatory. And we'll get into that a little bit. We've gotten into infectious. Some people have an infection in the spinal cord. Some people have a rheumatologic disorder, lupus or Sjogren's or sarcoidosis. And then there's this spectrum that you've talked about, NMO, ADEM, or acute disseminated encephalomyelitis, MS, idiopathic transverse myelitis, which is usually monophasic, but there is a version which is recurrent. Now, when we are evaluating a patient with a myelopathy, and I'll define that a little bit in a slide, the first objective is obviously to determine if there is a myelopathy. In other words, the spinal cord is simply not working. Bowel, bladder, sensory, motor, and pain are the cardinal features. The next step that's got to be done in the acute evaluation of these patients is there compression? Is there a disc herniation? Is there a tumor? Something like that. Once we've gotten beyond that, now it's to say, is this inflammatory? Is this an itis, right? Because transverse myelitis means there's an itis, which means inflammation. The best way to define inflammation is you got CSF leukocytosis, meaning white blood cells in the spinal fluid. That's why we do the lumbar puncture. Is there inflammation in there? You can look at CSF immunoglobulin production. Many of you have heard of this, oligoclonal bands or IgG index. It's a marker of inflammation. And the MRI helps because they give you that dye, gadolinium. And that dye, if it accumulates in the spinal cord, is a marker of inflammation. So that's how we go down this itis pathway. And if none of those are positive, then you start thinking about non-inflammatory causes of myelopathy. So, fourth objective, to define and evaluate non-inflammatory myelopathies. And then we need to know focality. In other words, where? Is it just at that one spot? Is it over 3 segments, as Dean Wingertuck told you? Is it multiple lesions? Is it also in the brain? Now, define the presence of the myelopathy. We're going back to that algorithm, which is that flow chart with the various boxes. 4 symptom groups to define a myelopathy. Motor can be all the way from complete paraplegia or quadriplegia. Quadriplegia means no movement of any of your 4 limbs. Paraplegia means no movement of your legs. Paraparesis is weakness of the 2 legs. Quadriparesis is weakness of 4 legs. Now, some people have very little, as I've told you, weakness, but the other issues are dominant. Sensory, can it be anywhere from numbness and tingling to an uncomfortable, deep, squeezing, band-like sensation? There almost invariably is some degree of autonomic dysfunction, meaning bowel or bladder retention or incontinence, and usually pain at some point in the presentation of an acute myelopathy. Now, again, getting to the autonomic, it could be urinary urgency. So what is that? That is a decreased interval from bladder fullness to evacuation. Very simply, it is you feel like you got to go, and if you don't get to the bathroom in the next 3 minutes, you're going to have an accident. Urinary urgency is the bladder contracting. And the bladder, when it's disconnected, essentially, from the brain, because of the spinal cord process, does the only thing it knows what to do when there's urine in it: contract. That contraction of the bladder muscle is the sense of urgency, and it just means that the bladder is irritable, and it can't be controlled. It could, somewhat worse, is actually urinary retention. With or without the sensation of bladder fullness, you cannot evacuate urine. Bowel urgency or retention, they typically go together. If there's bladder urgency, there's bowel urgency. If there's bladder retention, there's bowel retention. Sexual dysfunction is very common. All of these issues, the autonomic dysfunction, is more common on a transverse myelitis, an intrinsic spinal cord disorder, than something that's compressing on the spinal cord from outside. And many of you will tell us that there is pain, vicious pain. And in fact, when we first started this, we were very surprised when we asked, what is the greatest disability you've got? And we thought it would be the weakness, because many people are in wheelchairs. They said, no, it's not that. If I had to pick one thing to change, it's this. It's this burning, squeezing, tight, banding sensation, which can be very dominant and very debilitating. So as we're working through this, the first thing the treating physician needs to do is to rule out compression. And I'm talking hours here. I'm talking that if somebody has an acute myelopathy, you've got to define if something is squeezing the spinal cord within hours, because there's something to do. Surgically, there's something to do, and there's also a treatment that can be given, which is a trauma dose steroids. How would you suspect a compressive myelopathy? Well, what we're talking about here is hours to days, very, very acute, not the kind of myelopathy that percolates over hours or days to weeks. You may have an antecedent trigger. Many of you tell me that in the clinic, that something happened. You fell, twisted, turned, and that could cause, for example, a disc herniation or some abnormal mobility of the spinal column. And what we have to do in that case is you got to get into a collar, consider high-dose methylprednisolone, which is a really big dose. 30 milligrams per kilogram all at once turns out to be total of about 2.5 grams of methylprednisolone or solumedrol. Urgent neurosurgical evaluation and autonomic instability is a big deal here. Now, what if it's not so acute? What if it's days to months? Well, now we're not talking about those trauma dose steroids, but people in this group may be somewhat different. They may present with pain or nerve root damage, pain, a burning pain going down one side or the other. They may have some arthritis, and I'm going to show you a few pictures of an arthritic myelopathy where the bones are pushing on some of the nerve roots. Again, these people may have antecedent trigger. Sometimes people have postural coughs or headaches, where when they sit up, they get a headache as they cough. Here is such an example of a cervical spondylosis or arthritic myelopathy. So let me just tell you what you're looking at. Many of you have seen MRIs, but this is looking at the spinal cord from the side, and the spinal cord should be gray, and then around it on either side should be spinal fluid, which is white. And then the bones are just in front of, these are the vertebral bodies, just in front of the spinal cord. And then these black areas right here, anybody know what that is? Those are your discs. Those are your intervertebral discs. Those are the ones that get herniated and can cause pain or burning or even a myelopathy. And what do you notice here is that right in the middle here, C5, C6, in that area, it gets pretty tight, right? You don't see the spinal fluid on either side of the spinal cord. This is worrisome. So this could be, for example, a patient who's getting up there, a little in age, maybe middle age or older, and is doing fine, but if there is a fall or a motor vehicle accident, could trigger an acute compressive myelopathy. Most common cause of myelopathy in the elderly is exactly this, spondylitic myelopathy, which means arthritic myelopathy. You may not have much of an antecedent injury. It may be falling downstairs or a car accident, but it may be mild. Typically, the mechanism is hyperextension. So if you're hit from the back, your head will go back in an extension type of injury. That's the most likely to trigger the onset of a myelopathy. Again, we've got to immobilize the neck, and we've got to get special x-rays and MRIs. Okay, so let's take that out of play. Let's say we're talking about not a compressive myelopathy. There is nothing that's pushing on the spinal cord as we evaluate this. We've got to see if there's inflammation. And I just told you how we're going to do that, which is the lumbar puncture and the MRI. So if those are negative, we're going to look at non-inflammatory causes of myelopathy, or maybe we just missed it. We're going to have to repeat the spinal fluid test in a few days. So what kinds of non-inflammatory myelopathies would we be talking about? And I'm not going to go over all of these. There are strokes of the spinal cord, where there is a loss of oxygen to the spinal cord because of a blood clot. So that's an ischemic myelopathy, which can be a stroke, something like an arterial block, just like you would get anywhere else. If you got that in the heart, it's a heart attack. If you get it in the brain, it's called a stroke, the same thing. That's typically quite easy to see. Clinically, we can understand that and make that diagnosis quite quickly. But there are venous strokes, where it's the blood vessels that should be draining blood from the spinal cord, which get impaired. And that can cause a slowly progressive or stuttering myelopathy over weeks to months. AVMs, arteriovenous malformations, are collections of abnormal blood vessels in the spinal cord that can be asymptomatic for a long time and then can bleed or can cause an altered pressure in the spinal cord. Sometimes people have had spinal cord tumors, metastases, which are tumors from other locations, and there are a variety of other causes of non-inflammatory myelopathy. What we all check for are metabolic causes. So there are nutritional causes for myelopathy, and these always need to be looked at. Folate deficiency, B12, copper deficiency, thyroid abnormalities, or even toxic, such as heavy metal toxicity, and finally genetic. So all of those things need to be evaluated when thinking about somebody who's got an acute myelopathy but it's non-inflammatory. Now, what if it is inflammatory? And many of you have an inflammatory transverse myelitis or Devick's disease or ADEM or MS. So now we say, okay, listen, you've got your criteria for inflammation that are met. Is that associated with an infection? Is it associated with a rheumatologic disorder? Or is it associated with, for example, brain lesions? Now, I won't go into all of the things that would suggest to us a rheumatologic disorder such as lupus or Sjogren's or sarcoidosis, but fever, chills, night sweats, rash, adenopathy, swollen glands, blood in the urine. Those are the types of things that tend to tell us that there is a systemic process that is an autoimmune disease, and this is simply a manifestation of that. It's important because the treatments differ. And there are blood studies which we can test both for infectious and for rheumatologic or inflammatory disorders. For the infectious disorders, we get spinal fluid, viral, bacterial cultures. We get something called a polymerase chain reaction, which tells us if the virus is actually present. Lyme disease is something that we can sometimes pick up this way. Mycoplasma, something that can cause a pneumonia, but will cause a transverse myelitis. In some people, there's a zoster or shingles. And so if anybody's had shingles, you can see that there's a rash often on the torso or on the arms that reflects a reactivation of chickenpox. Well, if the chickenpox virus that is dormant within all of us reactivates, it can cause these vesicles or blisters, but it can also reactivate in the spinal cord and cause an infectious myelitis. Sjogren's syndrome, a rheumatologic disorder, an autoimmune disorder that often presents with dry eyes, dry mouth. Those are its most common features. There is a blood test called SSA or Rho, which is associated with that, and so many of you who have seen me get that blood test. There are ways to diagnose it which include a salivary gland or lip gland biopsy, which can define that autoimmunity or that inflammation within the salivary gland. Why is this important? Because it's coming back. So if you have Sjogren's syndrome associated with myelitis, it's much more likely to be recurrent rather than monophasic. Therefore, chronic treatment would be in order. When we treat transverse myelitis, we have to treat the acute phase, but we've also got to think, is there a chance of recurrence? And if there is, we've got to treat that. And we found, when we did a study, that if somebody has transverse myelitis, and they have that blood study that I told you about, which is Rho, or it's also called SSA, that those patients are much more likely to recur than patients who don't have that antibody. And so we use that in the clinic to help define those who are likely to recur. NMO-IgG is another one of those. And in fact, those two overlap to a large degree, those two tests. Sarcoidosis is an autoimmune disorder which affects multiple tissues, including the spinal cord and brain. It usually presents in the lung. It is typically relapsing. It is steroid responsive. Can involve the spinal cord, the optic nerves, the brain, even the covering of the brain. So in many cases, it can look like Devick's disease or MS or transverse myelitis. And so we'll usually do these tests, which are always done, but additionally an ophthalmologic examination and a special study called a gallium scan to define if there is sarcoidosis or autoimmunity in the lungs to help us sort between these possibilities. So all transverse myelitis patients should be investigated for signs, symptoms, and serologic evidence of systemic autoimmune disease. Sjogren's syndrome, sarcoidosis, and lupus. And if there is one of those, the disease is more likely to recur. I'm going to skip some of this because Dean Wingerchuk has told you this. Now, MS you know about, right? MS is by definition multiphasic and multifocal, right? So multifocal means multiple spots, and multiphasic means multiple phases occurring in a recurrent way. Well, if you have just your first attack of transverse myelitis, can we tell whether it's that alone or it's that associated with what will be multiple sclerosis? And the answer is yes. We can almost always tell. First of all, the attacks in MS tend to be very mild initially, sensory more than motor. People tend to not be in a wheelchair. They tend not to be catheter dependent. They tend to have more lesions even in the spinal cord. They tend to have oligoclonal bands. And I'm just telling you this because we can tell the difference even at that first presentation. Now I want to show you a little bit about transverse myelitis itself. Idiopathic transverse myelitis is an autoimmune post-infectious disorder in most cases. Most of you will say that you have had an infection that preceded the onset of neurologic symptoms. And it is the infectious agent which triggers the immune system to go amok, because that's what an autoimmune disease is. The immune system messes up, and it fails to distinguish appropriately between self and non-self. That's what a good immune system does. And when the good immune system recognizes a foreign substance, an infection, it eradicates it. An autoimmune immune system blurs that line and thinks that your own tissue is foreign. That failure of the immune system is triggered in most cases by an infection, and that's what we're talking about next door, is how that infection triggers the immune system to make such a mistake. Why is it just in the spinal cord? And what are these variations that put it on the spectrum that's different from, but close to, Devick's disease, or ADEM, or multiple sclerosis? Many of those things we're just getting a handle on and we don't completely understand. But these clues are coming. And so even in the last 3 to 4 years, there's been an amazing amount of data to help us kind of sort among these, and therefore to define better therapies, which, by the way, are on the way. So better therapies are coming. It is inflammation. This is a histologic section, which means a microscope section, showing you inflammation. Inflammation here is blue. These are all the immune cells that have gotten into the spinal cord, and they shouldn't be there. They should be in the blood, but not in the spinal cord. And the results of that inflammation are demyelination, loss of the cover, and varying degrees of axon injury. In some cases, it's mainly demyelination, and a milder case. In some cases, it's mainly axon injury and tends to be more of a severe case, demanding more acute therapy. We don't know what causes it, but there are multiple different causes, and we're getting there as well. 1 to 8 new cases per million people per year. So when I get somebody in my clinic and they say, how rare is this? I say, well, it's 1 in a million. And I mean it. It's 1 in a million. Now, those are the published statistics. I don't believe that. I don't think any of you believes it's that rare. It's much more common than that. It's misdiagnosed, it's called something else, or it's not reported. But it's still rare. If we accept those numbers, what we're talking about is 34,000 people in the U.S. at any time with morbidity or disease from transverse myelitis. Now, I won't go over all of the inclusion criteria because I want to show you a few other things. The inclusion criteria are that which I just went over with you. We've got to show there's no infection, there's no rheumatologic disorder, there's no compression, and indeed there's inflammation. These have allowed physicians throughout the world now to kind of make a uniform diagnosis of transverse myelitis, which we think helps with categorization, classification, and treatment. Now, Adam Kaplan is here, and he led this discovery of interleukin-6. Interleukin-6 is a cytokine that is very, very elevated in transverse myelitis to the tune of about 4,000-fold elevation in patients with transverse myelitis. It is a very powerful biomarker of transverse myelitis, and it helps to distinguish these other things that I've been talking about. Not only that, but it correlates with how robust, how severe the inflammation is, and the higher the IL-6 levels are, the worse the patient will do if we don't get very aggressive with our treatment. So we think this has been really a very important discovery, although it's not commercially available yet, to test and to dictate our therapy. This is just an example of how elevated it is in a group of you, transverse myelitis patients. In this, as a group, it's a 300-fold elevation, and that's the principal inflammatory factor that's in the spinal fluid. Now, I'll tell you why this is of importance to us, is that in a group who acutely has a low IL-6 level, virtually all of those people, 90%, have low disability 6 months later, are walking independently. Whereas in a high IL-6 group, none of those patients in this analysis walked independently again. Now, we didn't change treatment as a result of that because we didn't know this data, and now we do. Now, I will tell you a little bit about recurrent transverse myelitis, and these are just some of the factors that predict recurrence. If there is a longitudinally extensive lesion, 3 segments or more, patients are more likely to recur. If they have several spinal cord lesions, more likely to recur. SSA, or Rho in the blood, a blood study, predicts recurrence. IL-6 level to some degree predicts recurrence, but not perfectly well. And if somebody has optic neuritis, they're much more likely to recur. This is one case. This is one woman who came to me and ultimately had 2 attacks. So if you look at the dashed line here, this is her attack, and her disability was very high. She was not walking, and we gave her methylprednisolone and plasma exchange, and she got better. But guess what? Although she got better, her IL-6 levels did not go back to normal. They got lower than they were in the acute phase, but they stayed at about 50 picograms per mil, which is about 25 times what normal should be. And we were very scared that that was going to predict recurrence for her. And indeed, she did have a recurrence. She had another attack as her IL-6 levels went back up. And at that point, we made the decision for chronic therapy with Cellcept, which some of you are on. So she got acute treatment with methylprednisolone and plasma exchange, but then got chronically placed on Cellcept. And this only takes her out to 40 weeks, but she's now at 4 years, has never had another attack, and has done very well. So those are the ways we think about recurrence versus monophasic disease. And that's it.